There we go. Okay, terrific. So, it's interesting if we look back on this field, we talk about clinical trials and evidence-based medicine. So the 90s were the decade of the first big evidence for the benefits of lipids in terms of cardiovascular mortality, and this was the statin era. It started with the 4S. We continued this into the next decade, but in the 90s there were 5 major trials with statins completed, enrolling 30,000 patients, and everyone was extremely impressed with the evidence for statin benefit. Now it's interesting if we look at what's happened in this decade. So until 2013 there was no data that adding another therapy on top of statin, giving further LDL reduction, reduced events. 2014 improved it. 2017 48. Spire 1 and Spire 2, all of the program was stopped early. There still was data that showed benefit. And then the REVEAL study. So now, in a short period of time, in just the last few years, 5 trials with over 100,000 patients showing the evidence of further reductions in LDL cholesterol with non-statin therapy to produce clinical events. So I think we'll have obviously another round of guidelines coming up with this large set of data. We have one more study that will come out at the ACC that I'll mention. You saw the data on IMPROVE-IT. This was the first time. That showed just a modest benefit in reduction, modest delta in LDL, and there was a lot of controversy. Well, you treat these people, NT is 50, you're only having a relative risk reduction of around 7%. So what was interesting, and one of the most provocative abstracts I've seen out of the IMPROVE was shown at the AHA just recently. And I think this is a concept that I'll finish up with, but the thought of you can measure biomarkers to predict risk in not only primary but also secondary prevention. And as the last speaker mentioned, we used to lump it all together, you get primary and secondary prevention. So here's the IMPROVE-IT study. These people had ACS to get in. And they measured, this is a subset, they measured troponin T, NT-proBNP, hsCRP, and GDF-15. Now, how many of you measure hsCRP? See a show of hands. So if you look at cardiovascular biomarkers, the data is quite clear that the high sensitive troponins and NT-proBNP are much more effective in risk stratification than hsCRP. GDF-15, we don't have as much data on this, but so this was pretty clear. People who use a simple schema, 1 point for each elevated biomarker, and as you can see, the group that had 3 or more was a higher risk. There was a low risk group, but what's really interesting, look at this. So the people who are high risk, marked increase in risk, the absolute risk reduction of 7%, the NNT of 14 for a trial where the overall NNT was around 50. And then you can see the data in regards to intermediate risk. So an interesting concept that we're going to stand this theme of is there's a continuity of risk from primary through secondary. Let's go to the PCSK9 outcome trials, Fourier. So the primary results, you've all seen this, great reduction in LDL, about 60%. Overall risk reduction, primary endpoint, 15%. Once again, people say, well, that's a fairly modest event reduction. So let's go through some of the analyses afterwards. One of the issues was it was a short duration of therapy. The median duration only a couple of years as compared to other trials where it's much longer. This was presented at ESC. So basically, the lower the LDL, the lower the events. But very importantly is we want to look at both benefits and risks. And I think this is one of the key issues in terms of novel therapies. For example, in the field of cancer, there's tremendous excitement about these immunotherapies. However, what we're finding out is that some of the risks with immunotherapies are what? Multi-organ failure and death. So, you can't predict who's going to get it, and there's nothing to do when it happens. So, the worst types of side effects are those that you cannot predict and those which you cannot treat. Now, what happens here is that you treat people extremely effectively. The lower LDL says we saw no increase in any of the side effects. So it was remarkably safe. And I think that's one of the issues with monoclonals. At least these are fully human monoclonals that we've seen are very safe. We'll mention that we didn't see this with the human eyes, unfortunately. So the data with diabetics, once again, diabetics in Fourier, higher risk, but also greater absolute risk benefit and a smaller NNT than the overall study. No signal in this study, a large trial, 27,000 people, of new onset diabetes despite very aggressive LDL cholesterol reductions. So when we look at the trial, we typically talk about time to first event. When you treat a patient, are you only concerned about time to first event, or are you concerned about total events? Obviously, and if you're the patient, you're worried about all the events, right? I mean, we don't want to have a first event, but we don't want to have a second, third, or fourth one either, do we? So this is an interesting analysis. So it's an important thing. So there's the purity of the proof of efficacy. But when we talk about the effectiveness, we'd like to see what is the effect on everything else. So first events prevented, 219. Additional events prevented, 303. So when you only look at the prevention of the first event, you're actually missing, you're getting less than half of all the total events prevented. So it's just a hazard ratio, but as you can see, for second, third, fourth events, actually it was even greater with it. And here is the number of events prevented. For 1,000 patients, 3-year extrapolation, 22 first events, 52 total events. What does that mean? That means the therapy is also going to be, if we look at NNTs and cost effectiveness, considerations of other events, it may factor into that. Time for qualifying MI. People with a more recent MI had a higher event rate, greater absolute benefit. People with 3-vessel disease, also higher event rate, greater benefit. You heard about PAD. We know that people with PAD have increased risk. So PAD with MI in red, highest event rate. In yellow is PAD without an MI. Their event rate was a little higher than people who already had an MI for it. And this was very exciting data in terms of major adverse limb events. And what's shown here is something a little different. We typically, in the patients with PAD, we are obviously concerned about reducing heart attacks and strokes. But remember, particularly those who are symptomatic, is they don't want to lose limbs. And this was very interesting, a reduction in urgent revascularization and amputations, which was highly significant in this study. So it's something, and it was pointed out, is this due to effects on large arteries, or is this also due to improvements in microvascular circulation? Clearly, as you know, your diabetic patients suffer from both macro and microvascular disease. Once again, very high absolute risk, the event rate. And now we saw an NNT here of 25, much better than was seen in the overall study. And if you look at the group in patients with PAD and no MI or stroke, and you include both the cardiovascular and the major adverse limb events, the NNT is 16. So this shows a very interesting phenomenon. We're talking about higher risk people. They also show higher TIMI risk score, greater benefit in Fourier. Now the SPIRE 1 and 2 program got stopped because SPIRE 2 was interesting. That included primary prevention, and shown in here the LDLs were higher, but the number in primary prevention was also higher. It was about 19%, including FH and also including diabetics, and you could get in by having you heard about coronary calcium scores. This allowed high-risk people with coronary calcium scores to get in. LDLs were higher in SPIRE 2, the magnitude was greater, the reduction was more. As you can see, this is different from their studies. There was a loss of efficacy, and there was an increased anti-drug antibodies seen with this program. Nonetheless, now we're talking about a median duration of only a year. People with high LDL, including diabetics in primary prevention, FH, had a benefit with only a year median duration of follow-up. Odyssey outcomes, A little different now. We'll hear about ACC. They all had ACS before randomization with this. There were some differences in regards to titration up and stopping therapy, a longer duration. We'll have the results coming up in March. The REVEAL study with anacetrapib, this is not going to be available, but it still shows the concept of using a CETP inhibitor. Once again, a modest risk reduction of 9%. The longer the duration of therapy, the greater the benefit. Important theme, longer duration, more benefit. Now, anacetrapib raises HDL dramatically. The HDL went up 104%. The reduction in LDL, there's some difficulties because of the mechanism of reduction and the levels that low levels achieved. Free to wall equation doesn't work well, even direct LDLs don't work well. But by beta quant in the subset, the reductions were modest. Non-HDL cholesterol was only about 17%. And if you look at the prediction of benefit, it was all with the change in non-HDL cholesterol. So suggesting that raising HDL by this mechanism really did not give any benefit. It was all through LDL reductions, and Merck decided not to pursue approval. There is another phase 3 program with bempedoic acid in the pipeline. This is an inhibitor of ATP citrate lyase, and it's upstream of HMG CoR reductase. And so this is probably also the major mechanism in humans is upregulating LDL receptors. There's a phase 3 lipid program. You'll hear a lot about that in the coming year. There's also a CV outcomes trial, which is shown here, 12,000 people. It's testing in statin intolerance. This has a more modest efficacy, but when used with ezetimibe, and it will be also looked at the combination pill, can give about 45% LDL reduction in a non-statin therapy. Omega-3, as you heard about high triglycerides, we haven't had prospective trials. We've got 3 in the pipeline. The Reduce It is the one that will finish first. It's with pure EPA. Strength is a mixture of EPA, DHA, and Prominent is a selected PPAR alpha modulator. So we will get more data about this approach. Cantos is another approach of people with high CRP, and there was shown to be benefit. The benefit was greater in those who had the greater response to therapy, and it's something that Novartis will be pursuing in terms of the approval process. So let me wrap up here and at least get into some themes from what we have gone through. That basically, through a lot of data of non-statin trials of 400,000 people, the lower the LDL cholesterol, the better, and the longer duration of therapy, the better in regards to reducing cardiovascular events. Now, is that going to be a target or a threshold in the ACC pathway, which we were part of? We looked at the concept of you use a statin, and now there's a threshold of an LDL over 70 or non-HDL over 100, using both numbers, because that's how both Fourier was designed and also Odyssey Outcomes is designed. Because when you treat somebody, are you trying to get to less than 50, or and if they're really high risk, are you trying to get as low as you can go? That's a different philosophical concept here. And so I personally think that it looks to me that depending upon the risk, you may try to get as low as you can get rather than getting to less than 55. But that's for the future guidelines to discuss. Importantly, no safety signal for very low LDL cholesterol down to less than 20. And that's only 1 or 2 years of follow-up. We'll have more data about this in the future. There is an open label extension of the Fourier study. Reduction in first events. So when people say, well, you're only going to reduce events 15%, that is really not true for both longer periods of therapy, and also it doesn't count the second and third events. And interestingly, if you say, well, who should get treated? The higher the risk of the patient, based upon all the studies, and also out of the bococizumab program, the higher the LDL, because that means the greater the LDL reduction that you can achieve, the greater the potential benefit. Who are these people? Well, you can do it by clinical criteria, recent inline, multi-vessel CAD, peripheral arterial disease, kidney risk score. You can also do it by biomarkers. And I think and I admit I'm biased in a lot of research in biomarkers, but I think this has a great potential in terms of both primary and secondary prevention. Not only identifying the absolute risk of an individual, but also you can use the biomarkers. Don't forget, LDL is a biomarker. So you can use the biomarker to help determine who should be treated and also which pathway is involved with the residual risk. Is it a high LDL patient? Is it a high triglyceride patient? Is it someone who has a high level of CRP? What is their blood pressure? That's another phenotypic marker. Are they diabetic? It may be that, for example, some of the therapies, NT-proBNP and troponin I and troponin T, are great for heart failure risk prediction. You can also look at the risk for one event, MI, stroke, or heart failure. Because some therapies are going to be more for heart failure benefit, and some would be more for MI and stroke. And I think that will be a direction we go in the future, is rather than just saying that it's primary or secondary prevention, there will be a whole continuum of risk, including subdomain atherosclerosis for primary prevention with CAC scoring. There's actually been looked at this. You can use biomarkers and CAC and published this in Circulation with James Lemos, and you can get a risk assessment across a continuum, and also in secondary prevention. And I think we'll be able to better personalize which patients need which therapy. Thank you very much.